now. Charlene, over to you.
Yes, so as Prof. Low has mentioned, myelodysplastic syndrome is something that, I mean, it is a difficult disease to understand right from the lab to the clinical management of these patients. And over the years, from the time I started off as a registrar in the lab, to present, there's been many changes to the classification, new drugs being developed. And I'm glad that Prof. Low is on the call with us today, because he has, he's written a lot and helped us a lot to understand, make it much easier for us to actually study the disease. And so today we have two speakers. We have Dr. Ayanda Gugule Tujali, fondly known as Gugu. She is a hematopathologist and currently training in clinical hematology in our unit. She's based at King Edward Hospital. And I've actually given Gugu a selection of cases that I had seen through my years in the department. And it will just highlight the problems with diagnosis initially, where we did not have all the molecular markers, the lack of treatment. And the other important thing for us to realize is myelodysplastic syndrome to be diagnosed and managed, there has to be a very, very good relationship between the lab and the clinical team managing patients, because there's sometimes always a back and forth when it comes to making the diagnosis. So without further ado, I'll hand over to Gugu, and thereafter Honest will, I will introduce Dr. Honest Dewa to you. So Gugu, I will hand over to you if you can start sharing.
Oh, can you see my screen?
No, Gugu, I can't see your screen.
Let me do this.
Are you seeing the green icon at the bottom of your screen?
Yes, I am. I'm clicking on that.
Okay.
Okay. Okay. I'm not sure what's happening now.
Is your PowerPoint opened on your laptop?
Yes, it is. It is opened, so I'm not sure why it's not sharing. Okay.
Gugu, when you click on share screen, a number of small screens usually appears, and you choose the little one that's got your PowerPoint. If that doesn't work, Charlene, maybe we can start with Honest, and then
all right.
Gugu can email her presentation perhaps to you or me.
Sure.
We do that, Farah?
Okay. Gugu, how's it going there? Do you want to do that?
Okay.
Perhaps.
Can I email?
Yeah.
I'm not sure why it's not allowing me, because it was just now.
Okay, perhaps email it to both Honest and myself, and then one of us will try on our side. So I will introduce Honest in the meantime. So, okay. So I will hand you over to Dr. Honest Dewa. Is a very special person in our department. He's the only male amongst a whole lot of females. And he's a real pleasure to work with. So Honest is a physician who specialized in clinical hematology and obtained his examinations, his certificate last year. And he is an excellent person to work with. And so today he will be giving you a deep dive into the theory and the new developments in myelodysplastic syndrome. So, Honest, I'm going to hand over to you. I think you can stop sharing and yeah, so Honest can.
Okay, let me just.
Good afternoon, colleagues. Just checking if you can hear me.
Yes, we
can hear you
Honest,
well.
and we can see your screen.
All right. Thanks, Charlene, for the kind introduction. So today, I'm part of the team presenting myelodysplastic syndromes. Google will focus on case presentations, and I'll do mostly the theory behind the disease. The outline of my presentation will include an introduction, pathophysiology, and some epidemiology, the WHO classification, clinical presentation, diagnosis, prognostic scoring systems, and the therapeutic options that are available. And then I'll wrap up with the conclusion. So myelodysplastic syndromes are a group of related hematologic neoplasms that cause dysplasia and ineffective hematopoiesis, and they have a propensity to progress to acute myeloid leukemia. And this is important in the sense that in terms of treatment, it's one of the objectives that we aim to achieve, that is the to delay or to stop the progression to acute myeloid leukemia. The diagnosis of MDS requires morphologic dysplasia in at least one or more cell lines and or characteristic cytogenetic abnormalities. And just to emphasize that MDS is a malignancy and it is not a pre-malignant condition. Because it progresses to acute myeloid leukemia, some may think it is therefore a pre-malignant condition, but it is actually a malignancy in its own right, and therefore it needs to be treated. A bit on the epidemiology, it is common in older adults, but the precise incidence is not well defined. The median age is around 70 years, so it's basically a disease of the old. It is rare before 50 years, but when you consider therapy-related MDS, this entity can actually be found in younger subjects. It is more common in males in most categories of MDS, with the exception, of course, of the MDS with isolated deletion 5q, which we know is more common in women. So just to touch a little bit on the pre-malignant conditions that precede MDS, as I said, it is a malignancy, but there are some pre-malignant conditions that usually precede its diagnosis, and these include idiopathic cytopenia of undetermined significance, abbreviated ICAS, clonal hematopoiesis of indeterminate potential, abbreviated CHIP, and then clonal cytopenia of undetermined significance, abbreviated CICAS, and these usually for example, ICAS will have cytopenias, but with no clonality. And if there is dysplasia, it will be less than 10% for any lineage. And then when you look at clonal hematopoiesis of indeterminate potential, here there is clonality, but there isn't enough to define the entity as a myeloid malignancy. And then in terms of clonal cytopenia of undetermined significance, probably the worst of the three, here there is clonality with cytopenias, but again, the disease does not meet the defining criteria for a myeloid malignancy, but this has a higher incidence of progression into myeloid malignancies, whether MDS or acute myeloid leukemia. So in terms of pathophysiology, usually there is clonal mutation in the bone marrow that may result from things like genetic predisposition, for example, in families with germline mutations, or it may be due to stem cell injury as a result of exposure to things like cytotoxic chemotherapy, that we use to treat patients with other malignancies, like alkylating agents, like your cyclophosphamide, the topoisomerase 2 inhibitors, exposure to radiation as a result of a treatment as well, or other viral infections. A good example is HIV, very relevant in our setting. That may cause dysplasia, but may not necessarily cause MDS. And then, of course, toxic chemicals like your benzene. And then in most of instances, the cause may actually be unknown. And we know that there is a solid relationship with aging. Just looking at the model of the disease evolution in MDS, so there are risk factors, like I mentioned earlier, like germline predisposition, which may be an unmodifiable risk factor that a patient may have. And then you have other modifiable risk factors like smoking, exposure to radiation, and of course, aging. And then there is the issue of clonal evolution, where there's a founding event like a germline aberration. And then with a progression of time, there is acquisition of new subclones. And this may actually be orchestrated by these other modifiable risk factors. And then you start developing those cytopenias, and there may be epigenetic modulation. And with time, then with clonal expansion, the diagnosis of MDS may then be made, which can also then progress to acute myeloid leukemia. This table here just shows some predisposing factors that divided into heritable and acquired. And under the heritable, probably things to not include your Down syndrome, things like Fanconi anemia and Bloom syndrome. And then when you move to the acquired factors there, obviously mutagen exposure in the form of chemotoxic agents like alkylators, topoisomerase 2 inhibitors. And then of course, occupational exposures like your benzene, which may be occupational, or tobacco use, like I mentioned earlier. And then important diseases to remember in this regard include aplastic anemia, paroxysmal nocturnal hemoglobinuria, which is PNH, polycythemia, and of course, like in any other condition, obesity will always be a risk factor. So looking at the mutational landscape in MDS, it may look a bit busy, but to simplify this, all these genetic mutations that you see, there's only one that is associated with a good prognosis in MDS, and that is your SF3B1 mutation that you find in a fifth to a third of patients with MDS. And then the ones in brown are the ones that are known to have an independent poor prognostic impact on the disease. And these can either be transcription factors, they can be epigenetic regulators, or involved in mRNA splicing. So they include mutations like RANKS1, TP53 mutation, SXL1, EZH2, and SRSF2. And then the majority of these mutations that you see in blue, their prognostic importance is not well defined, but obviously not good. And they include a lot of mutations that we commonly see in acute myeloid leukemia. And some of them include your FLT3 mutations, your TET2, DNMT3, and the others. This is just to summarize the last picture that I showed, looking at the various mutations, their effect on prognosis and their frequency. For example, if you look at the SF3B1 that we said is associated with a good prognosis, it appears in about 30% of patients and is usually associated with the presence of ring sideroblasts. And usual treatment include drugs like luspatercept, which is an erythroid maturation agent. And then those mutations that are involved in DNA damage pathway, obviously the one includes the TP53 mutation that is associated with an unfavorable outcome. and seen in about 10% of all cases. And in terms of targeted therapy, there is investigational therapies that are being used, including APR-246. And then in terms of epigenetic regulation, there are mutations like EZH2, there is IDH1 and IDH2 that we see as well in acute myeloid leukemia, but these occur in a lesser frequency in MDS. And the treatment options include ivosidenib and enasidenib respectively, but just to note at this point that these drugs are currently not approved in MDS, so their use will be off-label. Just to touch a little bit on the WHO classification of myelodysplasia, I know Gugu will dwell much more into this classification, but just to check that, to see that there are about 5 categories that are used to classify the MDS into various categories, and these include the dysplastic lineages that are present, the number of cytopenias that the patient will have, and the percentage ring sideroblasts in the bone marrow, and then the amount of blasts in the peripheral blood and on the bone marrow as well. And then, of course, the cytogenetics that were involved by karyotype analysis. And then in terms of the presentation, how do these patients with MDS present? So the presentation may actually be related to the cytopenias that the patient may have. Anemia, which is the commonest cytopenia that we see in MDS. Obviously, patients can present with symptoms of anemia. They may be transfusion dependent, and of course, the attendant complications, including things like heart failure. And then fatigue is nearly ubiquitous and may often be out of proportion to the degree of anemia. So a lot of patients with MDS will report fatigue, even if the hemoglobin is not that reduced, but fatigue is quite a common symptom that is reported by these patients. And less frequently, patients will present with neutropenia and have things like recurrent infections and or thrombocytopenia, in which case they may present with bleeding symptomatology. And then a significant number of patients may actually be asymptomatic. They will have cytopenias and dysplasia, but they are not symptomatic. And usually these patients are those that will just be followed closely, probably every 3 to 6 months, looking at the accounts and determine whether they need treatment. And then some may present with B symptoms, but this is uncommon. And it generally represents late manifestations of the disease or transformation to acute leukemia. So if you see a patient with MDS presenting with constitutional symptoms, then you should be worried that this may actually be high-risk patient or a patient that is progressing or transforming to acute leukemia. Organomegaly, like splenomegaly and hepatomegaly are quite infrequent in MDS. And then autoimmune abnormalities in about a quarter of patients, you can see autoimmune abnormalities, and these have actually been blamed as part of the etiology of this disease as well. And then in terms of diagnosis, like the chairpersons have alluded to, diagnosis of MDS is not a walk in the park. It is quite a demanding exercise. And this will depend on a comprehensive history that should take into consideration things like prior chemotherapy, whether the patient has had radiation before, any concomitant medications that the patient is taking, things like alcohol consumption and smoking. And then things like bleeding, bruising, and infection as a result of the cytopenias that I talked about. And then other infections, again, like HIV, which is quite significant in the South African setting. Family history of inherited bone marrow failure disorders, quite important because we know the association between things like Fanconi anemia and a progression of the disease into things like myelodysplastic syndrome. So when you look at your peripheral blood, this is just summarized, it's not at all comprehensive, but just to give you know, an idea. So at least there should be one cytopenia. This is mandatory, and the monocyte count has to be less than 1, or else the diagnosis changes to chronic myelomonocytic leukemia, which is an overlap syndrome. The blast count has to be less than 20% as per definition of acute myeloid leukemia. And this will become important when we discuss the prognostic scoring systems, their shortcomings and how they are used today. And then pancytopenia is present in about half of the patients at diagnosis, and the reticulocyte count is inappropriately low because the bone marrow in myelodysplastic syndrome is usually overactive. However, the retic count will be inappropriately low for that cellularity. And then the anemia is usually macrocytic, or it may be normocytic, and the red cell distribution width is usually increased because of the ineffective hematopoiesis. So if the peripheral blast count is more than the bone marrow blast count, this may signal a more aggressive cause for the disease, and the patient will need closer follow-up. And then in terms of the bone marrow appearance, it is required for diagnosis, for classification and risk stratification in MDS. So every patient with suspected MDS needs to have a bone marrow done, and careful attention should be paid to morphology. Dysplasia in at least 10% or more cells in any cell lineage. And in terms of cellularity, mostly hypercellular, but we know that there is hypocellular MDS, especially the hypoplastic MDS, and also the blast count here is less than 20%. And then ORODs are uncommon in MDS, but when they are present, they are diagnostic of MDS with excess blast 2, regardless of the percentage of blast. And then on histologic evaluation, flow cytometry, cytogenetics, mutational analysis, gene sequencing, whether by Sanger sequencing or commonly these days by next generation sequencing, is quite important as well in terms of diagnosis, prognostication, and choosing the appropriate treatment. This is just to summarize some common cytogenetic abnormalities that may actually give a presumptive diagnosis of MDS in an otherwise unexplained cytopenia. And they could be unbalanced chromosomal abnormalities, or they may be balanced. These include your monosomy 7 or deletion 7q, things like deletion 5q, which is an entity on its own. And then in terms of balanced chromosomal abnormalities, they include translocation 11, 16, 321, and 211. In the absence of dysplasia or abnormal blood counts, other clonal karyotypic changes lack diagnostic specificity and are not sufficient criteria by themselves for a diagnosis of MDS. And these include your deletion Y, trisomy 8, and deletion 20q. These pictures are just showing some common dysplastic changes that we see in MDS. On the left here, we're just showing dysplastic red cells. And then dysplastic enucleation here, and then the red arrow showing basophilic stippling. And then to the right, we see the ever popular pseudo-U abnormality that we see in neutrophils. And this one again is showing ring sideroblasts, which is basically ferritin deposits in the mitochondria of the erythroid precursors, where you get at least 5 of those making up at least a third of the circumference. And then on the right, you have dysplastic megakaryocytes, some showing multiple small lobes that are seemingly disconnected, at least if you see this one on the bottom here. Okay, this table here is just showing some differences between the pre-malignant conditions that I talked about earlier, your ICAS, CHIP, and SICAS, comparing them to MDS in terms of cytopenias, the mutations, morphologic dysplasia, and the blast percentage. And as you can see, most of these, like for ICAS, it will just have a cytopenia and nothing else, with a low risk of transformation to AML. And in terms of management, it will just be bloods to follow up to see if there's any progression in the cytopenias or any dysplasia. Same applies to CHIP. There will be clonality, but without any dysplasia, significant dysplasia. dysplasia, and risk of transformation is also graded as low there. And when you look at MDS, then there will be cytopenias, there may be mutations, dysplasia, and the blast count may actually be increased. So this is just an algorithm waking up a patient who presents with unexplained cytopenias, where someone is probably suspecting one of those pre-malignant conditions or MDS itself. So because common things are common, we have to rule out things like nutritional deficiencies, vitamin B12, iron deficiency, folate deficiency, before we attribute this to any serious problem. Autoimmune diseases as well, we have to be ruled out, infections, toxins, or any other neoplastic process. And then if the cytopenias are unexplained, we can then go on to do a bone marrow aspirate biopsy. If there is dysplasia and increased myeloblast, this could either be MDS or AML, and this we can then ascertain with quantification of the blasts and other molecular abnormalities that are diagnostic of a relevant condition. And then when you look at the cytogenetic evaluation of the bone marrow, you have to look for evidence of MDS defining cytogenetic abnormalities or those that are defining for AML, and then classify as such. Usually in myeloid malignancies, MDS or acute myeloid leukemia, and NGS is usually performed in those centers that have access to it, looking at genes that may be associated with myeloid malignancies. However, if there is no evidence of clonality, this will be defined as ICAS. If there is somatic mutation, but the variable allelic frequency is more than 2%, this could be defined as CICAS. And then moving on to the prognostic scores in MDS. So we score, we prognosticate MDS by using certain values to classify it whether it's lower risk or higher risk, and this will then determine what route to take in terms of management. So there are two common scoring systems that are used, which is the IPSS, the International Prognostic Scoring System, which has been in use for probably 2 decades and a half. And then the revised edition of that, which has been in use for probably 12 or so years. And for MDS subtype to be classified as lower risk, it has to have an IPSS score of 1 or less. And then on the revised score, it will have a score of 3.5 or less. And then the ones that are classified as higher, on the IPSS score, they will have a score of at least 1.5. And on the revised score, it will have at least a score of 4. So we'll go through some of these. So when you look at the IPSS, it's based on 3 parameters. It's based on your blast count, it's based on the number of cytopenias that the patient has, and it's also based on the cytogenetic risk group. And these can have a score of 0 up to 2. So like I said earlier, that the diagnosis of MDS depends on a blast count of less than 20. You would notice that using the IPSS scoring system, they also had a score of 2 for patients with the blast count of 21 to 29, and also a score of 1.5 for those with a blast count of 11 to 20. But we know that by today's definition of acute myeloid leukemia, these patients would not be classified as MDS, but rather acute myeloid leukemia. So that is one drawback of this scoring system, but we'll look at that later on. So using the IPSS scoring system, the patient can be grouped into 4 different groups, either low risk, intermediate 1, intermediate 2, or high risk, depending on the score that they get. And when you move on to the revised edition of the IPSS, it uses also the same parameters, cytogenetic group, blast count, and cytopenias, but this now is not just looking at the number of cytopenias, but is looking at the depth of the cytopenias. So the cytopenias in here are clearly defined: hemoglobin, platelets, and neutrophil count. For the hemoglobin, for example, it will be graded as whether is it less than 8, is it between 8 and 10, or is it more than 10? And then platelets less than 50, between 50 and 100, and more than 100. And then for neutrophil count, if it's less than 0.8 or more than 0.8. And according to this scoring system, the patients are then grouped into 5 different risk categories, very low to very high. And when you look at overall survival in these patients, those scored as very low risk approach about almost 9 years median survival in years, and those with very high risk, that's less than a year survival. So on this table here, I just included different types of scoring systems. There is the IPSS there, number 1, number 2, the revised one that we've just discussed now, and then the parameters that they use, which is karyotype, blast counts, number of cytopenias, or the degree of cytopenias for the revised one. And then there is an MD Anderson Cancer Center prognostic scoring system that they use. It also includes karyotype, blast count, degree of cytopenia, but it adds on the age of the patient, it adds on the performance status, and also a prior transfusion or the transfusion needs of the patient. And this probably gives you more information to accurately score the patient. But some people would think it's a bit more complicated. It's not probably practical, but probably it gives a better prognostication of the patient. And then there's one other one that uses called the genoclinical model. And this, on top of the degree of cytopenias, the blasts, and the karyotype, it also adds the age of the patient. It also adds the gender, and it has a number of mutations that it includes. And we all know that the mutations in MDS these days have become very important in terms of prognosticating these patients, possible targeted therapies, and so on. So these other scoring systems may probably give more in terms of probably even upgrading the score of the patient from lower risk to higher risk. But the question is it practical? For example, in our setting, how easy is it for every patient to do that? But I think with time, probably there will be a combination of all these scoring systems to come up with something that probably will define these patients better. This is just a pictorial depiction of what I've been talking now on one page, looking at the different types of scoring systems and what they look at. For example, the IPSS and the IPSS revised, we're looking at the blast count, the cytogenetics, and the cytopenias. And then when you look at the MD Anderson prognosticating system, you can look at the parameters that they use and how they apply that and score the patients. So what are some of the limitations of these two popularly used scoring systems? That is your IPSS and the revised version. So let me say they are the commonly used ones, and they have been validated in many patients and they remain useful, but however, they probably can be modified to be better. So some of the limitations of these scoring systems is that these scoring systems were developed in patients who were managed primarily in a supportive way rather than with disease modifying therapies. So for example, the IPSS, when it was developed, there wasn't much treatment in terms of MDS apart from supportive transfusions and watchful waiting. But however, let me hasten to say that these scoring systems have been validated in the new era, and they are still relevant. These models were created using an outmoded MDS classification system, probably the 2008 one. Like there's another classification that I didn't talk about there, the WHO one, which is based on the old classification of MDS. And this included patients who would currently be diagnosed with acute myeloid leukemia. I think I already alluded to this point, that the IPSS system has scores that have a blast count above 20, which in this day will not make it an MDS anymore. And then these scoring systems, that is the IPSS and revised version, are static. They are primarily used at diagnosis, and they've not been well validated for estimating prognosis at a later time points or after treatment. So they are not very dynamic. For example, you can have a patient today who has probably MDS with isolated 5q deletion and responds to treatment with lenalidomide. After 2 years or so, the patient loses the response, and you repeat the bone marrow with NGS, and you see that they've acquired TP53. Using these scoring systems, then it becomes difficult to give them a score. These two scores also cannot be used for prognosis with both therapy-related MDS and de novo MDS, because they were developed primarily for de novo MDS and not therapy-related MDS. And of course, glaringly, they do not incorporate molecular data, which usually affects management and prognosis, like the one that we showed earlier, the genotypical one. And then the effect of age, comorbidities, transfusion dependence are also not captured in these two scoring systems. And I think I showed earlier on that the MD Anderson and the other scoring systems try to include the effect of age, the transfusion dependence, and so on in their scoring of patients. And on the right, I was just looking at the patient to say, how do we approach a patient? Because this is a heterogeneous disease, and there is need to individualize this scoring and even treatment. So obviously, we have to look at cognitive function of these patients, the age, patient-reported outcomes, transfusion needs, whether there is iron overload or not, and other parameters, like the LDH, ferritin. We know that these speak to disease burden and also have an effect on the prognosis. And then the issue of comorbidities, presence of other infections, and the performance status. And then, without saying much, on the bone marrow, things like your molecular abnormalities and the bone marrow niche itself, skeletal health, and other things. So how do we try to then personalize these prognostic models so that they do fit each and every patient that we see? So we can try to look at patient-related factors in terms of prognosis, and these will include your age. Obviously, a 70-year-old and a 55-year-old will fare differently in terms of if they have the same disease. And then the performance status, there are various scores that you can use for assessing performance status, including the ECOG, the Karnofsky, and the Felt scores. And then the comorbidities, of course, looking at the cardiac, pulmonary, renal, liver, and all other comorbidities that patients may have. And then when you look at the disease-related factors to consider, you can look at the classification of the WHO 2016 that we currently use. And obviously, though it's not used as part of prognosis, for example, if you take a patient with excess blast 2 and a patient with excess blast 1, obviously the one with excess blast 2 may fare poorly because there's more blast there, they may progress further. So all those issues, I think they should actually be taken into consideration. Then you look at things like flow cytometry. Surely some flow markers speak about prognosis in terms of any myeloid malignancy. And then clinical variables to consider, apart from the hemoglobin, white cell count that is already incorporated here, and the blast count, I think other parameters like LDH, ferritin, and albumin can also add value to these scoring systems. And then the biological variables, things like cytogenetics, DNA sequencing, RNA sequencing, methylation profile, and microRNAs. I think these are things that probably will take center stage going forward in terms of the investigations and prognosis of these patients. And then in terms of the classification, we've said there is lower risk and higher risk. So I'll just go over a low risk and this management, and then discuss a little bit about high risk MDS as well. So those with lower risk MDS, according to the revised, we said they have a score of 3.5 or less, and their risk of AML progression is lower when you compare them to the higher risk group. And 50% of elderly patients who are in the lower risk category die of other causes other than the MDS or AML. So the priority in these patients, therefore, is generally the treatment of the cytopenias, which is mainly anemia, and improvement in quality of life instead of trying to gun for cure, or you don't need to be very aggressive in a patient with lower risk MDS, and especially if they are elder. So I'll just look a little bit about a few types of the MDS that are regarded as low risk. I'll start with the MDS with isolated deletion 5q. And in terms of the diagnostic criteria for this patient, these are distinguished by anemia with or without other cytopenias. They may have thrombocytosis. There is presence of an isolated deletion 5q or with other additional abnormality, but the additional abnormality should not be monosomy 7 or deletion of 7q. Bone marrow blast count is usually less than 5%, peripheral blasts usually less than 1%. And on the bone marrow, you see micromegakaryocytes, which may be monolobulated or bilobulated, and frequently exhibits erythroid hypoplasia. Usually in DEL5q, there are no OROs. There may be 1 to 3 dysplastic lineages, 1 to 2 cytopenias, and there's any level of ring sideroblast does not affect the diagnosis. In terms of the clinical features, like I said earlier, commoner in the older women, median age is around 65 to 70 years old, usually marked by refractory macrocytic anemia, and platelets may be normal or increased. Usually there isn't any significant neutropenia, and there's low incidence of bleeding or infection. However, red cell transfusions are frequently required, and this disease relatively runs a benign course compared to the other types of MDS, and the incidence of transformation to acute leukemia is relatively low. And there's also quite good response to lenalidomide, and the presence of a TP53 mutation leads to poor response to lenalidomide cytogenetically, but some patients can still achieve transfusion independence. So if you are treating a patient with a deletion 5q with lenalidomide and they develop a TP53 mutation, yes, you won't get cytogenetic response, but you can still achieve transfusion independence, which may be actually very good for a patient because then they won't be tired, they won't need to come to hospital frequently. So the presence of TP53 mutation in a patient with DEL5q with lenalidomide does not mean that you should stop the patient to give lenalidomide. And then the patients with SF3B1 mutated MDS, it is often considered a distinct subtype of MDS, also considered to be a bit indolent. And this mutation has positive prognostic value on the overall survival. However, mutations in other epigenetic regulators like TET2, DNMT3A do not appear to affect survival of these patients. But however, the presence of RANKS1 and EZH2 have significant impact on the prognosis. And then let's move generally to the treatment of these patients with low risk disease. So MDS is a heterogeneous disease, and treatment should therefore be individualized, and the goals of therapy should be clearly defined, and they should match the goals of the patient as well. So selection of treatment is influenced by severity of symptoms and cytopenias, the classification, prognostic category, medical fitness, and patient preferences. And the goals of care should be revisited periodically during the course of the disease because they change depending on which direction the disease is taking. If you are aiming for cure, allogeneic stem cell transplant is the only currently potentially curable alternative that we have. You may aim for transfusion independence, improve cytopenias, quality of life, prolong survival, while at the same time minimizing treatment-related toxicity. And your options include watchful waiting, depending on the prognostic risk, blood products like blood transfusion, and this should be coupled with adequate iron chelation, growth factor usage, either erythropoiesis stimulating agents, thrombopoietin agonists, or things like Neupogen. And then we have hypomethylating agents that are commonly used in high risk and other low risk patients. And then immunomodulator drugs like lenalidomide, and then immunosuppressives like ATG combined with cyclosporine in those with hypoplastic MDS. So in terms of supportive therapy, these things include things like antibiotics, transfusions, iron chelation, and of course there has to be continuous assessment of these patients to look at the transfusion needs and progression of the disease. So in terms of treatment of the anemia, so treatment of low risk MDS is relatively simpler when you look at the treatment of higher risk MDS, because in low risk MDS, basically what you're targeting are the cytopenias. If the patient has anemia, you want to try to tackle the anemia. If the patient has thrombocytopenia, you want to try to treat the thrombocytopenia. So anemia being the most common cytopenia is present in about 89% of all monitored. Response to therapy is influenced by the MDS prognostic category, level of baseline serum EPO levels. Usually those with an EPO level of less than 500, but some are moving to a level of 200 now, and the degree of transfusion dependence. So the ESAs will work more in patients in a patient who is not transfusion dependent. And then response is usually assessed in about 6 to 12 weeks. So you cannot say the patient has failed to respond if they've taken response around 5 weeks, and the duration of response neutropenia, which may actually be quite problematic for patients with MDS. Then lenalidomide as a drug for low risk MDS. It is approved for the treatment of MDS patients with transfusion dependent anemia due to low risk MDS with isolated deletion 5q with or without additional cytogenetic abnormalities. This drug is active even in patients who before transfusion dependence, but however, it does not delay progression to AML. And the 10 milligram dose is more effective than the 5 milligram dose in inducing transfusion dependence. That was 61% versus 49 in studies, and cytogenetic response with a similar safety profile. So 10 milligram dose is the favored one to start with. And it should not obviously be used in patients with severe renal failure because of the lenalidomide side effects and those with severe cytopenias. And then the effect of TP53 on transfusion independence, cytogenetic response, and survival, of course, is negative. But like I said earlier, patients may still attain transfusion independence. Then luspatercept as a treatment, this is an erythroid maturation agent that can improve anemia in MDS by enhancing late-stage erythropoiesis. It reduces aberrant CMAD2 and 3 signaling by binding the transforming growth factor beta superfamily ligands. It is most effective in patients with ring sideroblasts. But let me just say at this point that both lenalidomide and luspatercept can actually be used in patients who have failed to respond to erythropoiesis stimulating agents like erythropoietin. But however, this for lenalidomide, this is an off-label use, but there has actually been reports and studies that have indicated that some patients actually attained transfusion independence after failing on ESAs when they were given lenalidomide. And luspatercept as well can actually be used in patients who have failed to respond to ESA therapy. So the initial dose for luspatercept is around 1 milligram per kg, which is given subcut every 3 weeks, and it is generally well tolerated. Toxicity primarily involves fatigue, diarrhea, and asthenia. And in the MEDALIST trial, luspatercept was compared to placebo in patients who had ring sideroblasts and who were transfusion dependent. And the primary endpoint was transfusion independence for more than 8 weeks. And that was 38% for those who received luspatercept and about 13% for those who received placebo. And then when they extended to the secondary endpoint of transfusion independence for more than 16 weeks, which was done over 48 weeks, those on luspatercept, there were 28% who achieved transfusion independence versus 7 for those who received the placebo. And then in terms of thrombocytopenia, it is present in about half of patients with lower risk MDS, and hemorrhage leads to death in about 13%. Intrinsic functional defect of dysplastic megakaryocytes increases bleeding risk, as does concurrent medications frequently used in elderly patients, like aspirin and platelet inhibitors. Platelet transfusions and thrombopoietin receptor agonists are first-line treatment options. But however, we know that platelet transfusions are not durable, that they are highly immunogenic and contribute to splenomegaly. So therefore, the thrombopoietin receptor agonists become the go-to therapy if you can get them. And these lead to durable platelet increases in patients with lower risk MDS. For example, trombopag treated patients have significant lower bleeding events, which was about 14 versus 42, and a higher rate of platelet response, 47 versus 3% compared to placebo. And then median time to response is around 2 weeks, so it's quite good. However, they lead to increased blasts and fibrosis in the bone marrow, but rates of AML progression and overall survival were not significantly different. And this actually, they noticed that patients who had thrombopoietin receptor agonists had increase in blasts, but when they stopped the drug, the blast count returned to baseline. So there wasn't any significant outward effect of it. So, however, it is advisable to avoid using thrombopoietin receptor agonists for patients who have more than 5% bone marrow blasts, as there's a risk of leukemic transformation. Patients who are not heavily platelet transfusion dependent and who have an endogenous TPO level of less than 500 are the most likely to respond and benefit from this therapy. And then use of growth factors like Neupogen, there isn't any clear benefit besides supportive therapy in cases of neutropenic sepsis, and they can actually be combined with other growth factors like ESAs to improve responses. The risk of leukemic transformation is low or to negligible, and survival was, of course, shorter in patients with a higher percentage of blasts if they received growth factors. And then in terms of immunosuppressive therapy, this can be used in patients with hypoplastic MDS, and this leads to transfusion independence in patients with lower risk MDS. But patients who are likely to respond to immunosuppressive therapy are those who are less than 60 years with a low level of blasts, those with a hypocellular bone marrow, and those with a PNH positive clone. And also they noted that those with an HLA-DR15 positive were also likely to respond to therapy. So ATG with cyclosporine can actually produce hematologic responses. So it is an option for patients with hypoplastic MDS. And then hypomethylating agents, they actually have changed the landscape of MDS treatment. And these drugs are effective even in patients with unfavorable cytogenetics or TP53 mutations in which chemotherapy has failed. And then although azacitidine and decitabine can induce hematological and cytogenetic responses, they do not eradicate the clone. And azacitidine can be given IV, subcut, and there is an oral formulation now. Then decitabine can also be given IV or subcut, and responses may take up to 4 to 6 cycles. So you have to persist for at least 4 to 6 cycles before you say the patient is not responding to treatment. And treatment should continue as far as the benefit persists and the medication is tolerated. And then if a patient does not respond to one hypomethylating agents, they are unlikely to respond to the other. So this was just a study showing the survival of patients who were treated with azacitidine compared to conventional care, and it clearly showed the benefit of azacitidine in those patients. Then there are those patients that we classify as low risk, but they're actually high risk, and I've put in brackets there to say indications for stem cell transplant. So there are patients that, according to the scoring systems, they'll be scored as being a lower risk, but when you look at them, they're actually high risk. And which are those patients? So these patients are those where they have grade 2 or higher fibrosis in the bone marrow, those patients with dramatic transfusion requirements or ever increasing transfusion requirements, those with complex karyotype, and patients with TP53 ranks 1 mutations, and patients with a genetic predisposition. So these patients, I would say, it's better to try to work them up for a transplant early if they have a donor available and if they are fit enough to undergo a transplant. And then, of course, the issue of targeted therapy studies ongoing to try to treat these patients who have targetable aberrations. We know, of course, those with the del5q who use lenalidomide, those with ring sideroblasts will respond to luspatercept, and those with IDH1 and IDH2 will respond to ivosidenib and enacidenib. But however, these drugs are not yet registered for use in MDS. And then the mutant P53 mutation, the APR246 is investigational, but has been seen to reactivate the mutant P53 to induce programmed cell death. And there are other targetable aberrations, as shown on this cartoon here, where things like your venetoclax, your JAK inhibitors, and so on, are actually being tried in patients with MDS. And then this, just to summarize, approach to treatment in low-risk MDS. Like I said, the treatment of low-risk MDS is a bit straightforward when you compare to higher risk, and you are targeting the cytopenias, which will be your anemia, thrombocytopenia, and pancytopenia. And the options are there. You start usually with your erythropoiesis-stimulating agents after measuring your erythropoietin level to determine whether the patient will respond or not. And then if they fail that, you can go for things like luspatercept or lenalidomide, and an option of clinical trial always available in a place where you can get those. And then high-risk MDS, the treatment here is a bit complex. A more aggressive treatment strategy, including hypomethylating agents and allostem cell transplant, with the aims of delaying disease progression, improving survival rates, and potentially curing the disease is employed. Evaluation of medical fitness, including performance status, physiological fitness, and cognition must be done prior to treatment. And it is better to proceed with stem cell transplant while the patient is still responding to hypomethylating agents than wait for the patient to fail treatment. The outcomes have been shown to be poor there. If an HMA is selected for treatment of MDS with mutant TP53, some experts have advocated for use of decitabine over azacitidine, but there isn't strong evidence for this. Meta-analysis concluded that for patients with a very high-risk disease, early stem cell transplant is associated with the maximal life expectancy. However, cytoreductive bridging therapy is an acceptable alternative in the following settings. So if identification of a donor is expected to be delayed, then you could actually bridge with a cytoreductive therapy or AML-like regimen while it's waiting for the transplant. And for patients with circulating blasts of more than 10%, especially if they will not receive a myeloablative preparative regimen. So you can actually employ an AML-like regimen to try to debulk the disease prior to transplanting. And this is just an algorithm for the higher risk MDS. So the main therapies here include your hypomethylating agents, stem cell transplant, or base supportive care, depending on the fitness of the patient and whether you are going to use chemotherapy before you go to transplant. That is dependent on center to center and dependent on a physician treating the patient. So transplant, does everyone with MDS need transplant since it's the only curable option? So life expectancy is maximized when transplantation is delayed for those with low risk disease. So in low risk disease, you should not rush to transplant, but in those with high risk patients, actually to try to go into transplant early has been seen to improve survival. There is no definitive evidence of a survival benefit associated with administering chemotherapy before a stem cell transplant. But like I said earlier, some will use it in those patients who have a higher percentage of blasts in the bone marrow. And then where are we going right now? So like Prof. Law said in his introduction, there is a lot of studies going on to try to improve the armamentarium that we have for treatment of MDS, and there is a lot of oral drugs, some intravenous, that are being investigated at the moment, targeting various aberrations that we find in MDS. And just to leave you with this, This patient, we recently got this patient from the private sector. She's a 66-year-old female patient who had an MI in April 2021. She had also a stroke in the same month, which was complicated by memory loss. She was diagnosed with MDS with excess blast 1 with fibrosis in September 2020. And NGS at that point showed SF3B1 mutation. Here, hemoglobin levels range between 4.9 to 8.2. White cell count has been normal. Platelet count has been normal. There are no recurrent infections and no bleeding. She's currently transfusion dependent, requiring at least 1 unit of red cells every week. And her transfusion needs have increased over the past few months. Erythropoietin level is currently pending. So I would want to know from the audience, what would you do with this patient? Currently, we're just managing her with supportive transfusions, and those in private sector can also tell us how to approach this patient, whether you repeat the NGS to see whether there's progression, or you wait and see whether she can benefit from erythropoietin. Or let's say the erythropoietin comes out and it's more than 1,000, probably she's not going to respond. How are you going to manage her? And then in terms of my conclusion, MDS arises from a stepwise acquisition of mutations in hematopoietic progenitor or stem cells. Aging and exposure to alkylating agents and other chemotherapeutic agents are all risk factors. MDS occurs most commonly in older adults, and there is a male predominance for most categories, and anemia is the commonest cytopenia that you see. And then adding molecular data to prognostic models may improve their predictive power. Things like vitamin B12 and folate deficiency, HIV, copper and alcohol abuse, medications like methotrexate can all cause cytopenias and dysplasia and must be excluded in trying to get the diagnosis. Patients with heavy transfusion needs are less likely to respond to ESA therapy, even with low erythropoietin levels. Allo stem cell transplant remains the only routinely curative approach in MDS. And those were some of my references.
Thank you, Anis. That was an excellent overview. You've really done justice to the topic. I'm going to not go on to the questions right now because due to lack of time, I think let us go on to Gugu's talk. And Anis, if you could stop sharing, then I'll share my screen. Okay, so this is quickly some of the cakes that I've made. And yeah, so this is why they call me the Bloody Baker. And this is us having some fun at the end of the year last year. And I'm going to share Gugu's talk. Okay, Gugu, can go ahead. I'll mute and I'll, sorry.
Okay. Afternoon, everyone. Sorry for the glitch earlier. Thanks, Charlene. So I'm going to go through a few case series of MDS. So the first patient that we have is Mr. RM, who is a 66-year-old male who presented in 2010, was referred from the vascular department. He had worked as a bookkeeper living in North Beach in Durban, and with a background of hypertension, control on medication, type 2 diabetes, controlled on diet, dyslipidemia. He was an ex-smoker with a 40-year PEC history, also peripheral vascular disease with the right tib peroneal disease, ischemic heart disease, and also lumbar spondylostasis with less than 25% at L5 is 1, and he was RVD negative. He was treated with enalapril, simvastatin, Izodil, and had been previously on aspirin, but was stopped when he presented. He had no other occupational exposures to radiation or chemicals and had 5 siblings. So he presented with tiredness and shortness of breath, and he had also noticed blood in his sperm. He had no recurrent infections or constitutional symptoms. And on systemic inquiry, also had intermittent claudication with about 50-meter distance and also a grade 2 dyspnea. On blood counts, they revealed that he had a thrombocytopenia. He then had a bone marrow biopsy done at his base hospital, which showed features of myelodysplasia with blasts, query refractory cytopenia. However, no cytogenetics were done. So on examination, when he was seen, he was otherwise stable. The cardiac had nothing of note, and also the abdomen and all the other systems. So his assessment was that of arteropathy, complicated by peripheral vascular disease and also ischemic heart disease, with features now presenting with newly diagnosed MDS, refractory thrombocytopenia with 5% blasts, and also had a microcytosis. So the initial bloods in 2010, his HB was 12.9. However, he did have microcytic and hypochromic, white cell count 5.3, and his platelets was 42. His iron studies were seen to be low at this point, and he was started on iron therapy. Next slide, please. So his bone marrow in 2010, at this point, his platelet count was 57. It was normal cellular to hypercellular. He did had megakaryocyte atypia or dysplasia. He had monolobed and hyperlobated forms and also micromegakaryocytes. The myeloid series was sequential maturation, and there was some hypogranular neutrophils. Erythroid was normoblastic in maturation, and there was a decrease in his iron stores of 2/6 with no ring sideroblasts, and there was 5% blasts noted. And the comment was that the features are consistent with the myelodysplastic syndrome. However, the cytogenetics done at that point were not done due to the specimen that had deteriorated. So based on the information that we'd had, his IPSS-R score was 3.5, would put him at an intermediate risk, which has a 3-year median survival with a median time to 25% AML evolution of 3.2 years. So on the side, we've got pictures depicting the hyperlobated forms and also monolobed megakaryocytes. Next slide, please. So upon monitoring the patient in 2011, his platelet count went up to 19 due to the start of his decitabine, which was approved for him. So he was started on decitabine, and his platelet count started to increase from about 42 average in 2010 to about 90 in 2011. Next slide, please. In 2012, his platelet counts were maintained, and he wasn't transfusion requiring, and he was still on the decitabine. However, in 2013, he started developing cytopenias, and a repeat bone marrow aspirate and trephine was done to investigate this. Next slide, please. And when that marrow was done, he had a platelet count of 60, and the consolidated report showed that the current findings were of a unilineage dysplasia on the megakaryocyte, and the blast percentage had increased to about 7%, which was in keeping with an MDS. However, there was no evidence of transformation at this point, and his cytogenetic were of a normal male pattern. So in 2013, he was continued on the decitabine, and his platelet count subsequently improved. And also in 2014, his platelet counts were improved at about 198. Next slide, please. However, in 2015, he then started developing cytopenias again. And however, there were no peripheral blasts seen. So another bone marrow investigation was done at this point. Next slide. Next slide, please. So in 2015, a bone marrow aspirate and trephine was done. His acid-fast bacilli were confirmed on the Zell-Nielsen stain. However, still no increase in blast. He wasn't in transformation, and also he had a normal male pattern. So at this point, his decitabine was stopped. This was due to the TB, and also he had low performance status. Next slide, please. So he received the treatment for about a year. And then the TB treatment for a year. And then in 2016, around about June, it was put back on the decitabine. However, it then presented with symptoms of coughing that were not getting any better. And on a chest X-ray, it was noted that he had a right upper lobe lesion on the lung, which was then biopsied. Next slide, please. So with this treatment plan was initially started treatment in 2012 with a decitabine at 50 milligrams daily for 4 to 7 days. In 2015, it was stopped due to the TB and also the fact that he had a poor performance status. In 2016, it was restarted right about June, however, stopped again in November due to a biopsy result of adenosquamous carcinoma that was found from that right upper lobe lesion biopsy. And then he was referred to oncology. However, in 2016, December, the patient demised. So with the second patient, it's Mrs. TG, a 49-year-old female, was referred from King Edward Hematology Department to start on the Vidaza trial. Initially, it presented in 2004. She lived in KZN and worked as a domestic worker. I had no background medical history. She was assessed as a low-risk MDS and was not transfusion requiring. She was RBD negative and was on an EPO at 30,000 international units weekly and also paradoxin 25 daily. She had 1 sibling, 2 children, and had no history of smoking or drinking or any other occupational exposures. When she was seen on examination, she was fairly stable with nothing to note on her physical examination. So the plan was to await the approval for the Vidaza trial and to continue her EPO and paradoxin. And then she was started on danazol due to the low platelet count. However, we couldn't really find her bone marrow results or cytogenetics as this was done in 2004, and we didn't have access to those results. Next slide. So when she presented to us in 2011, she did have an anemia of 9.3 and a thrombocytopenia of 21, also a mild leukopenia of 3.78. So she was then observed from 2011 through to 2012. Also in 2013, those were blood trends. They were fairly low. She wasn't really responding much to the danazol. Platelets were less than 20. And then, and she wasn't transfusion requiring, even though her HB fluctuated above 10 and also was going to values of about 8.7 in 2014. Next slide, please. Next slide. Next slide. Yeah, so 2017, her HBs had dropped and also a platelet had dropped around February to about a month and was getting about 1 bone marrows. Between that time, she had about 2 bone marrows done between February and October. However, none of them showed any disease transformation or increase in bloods, and there were no cytogenetic abnormalities. In October, she then presented with an HB of 7.4. A white cell count had increased to 94.8 and the platelets were 10. And then she had about 65% blast on that peripheral smear. Then we went on to do a bone marrow aspirate and trephine. Next slide, please. Okay, where the flow cytometry confirmed an acute myeloid leukemia, where about 84% of the cells showed a typical blast morphology and scatter patterns. Next slide. And also her bone marrow aspirate and trephine also confirmed an acute leukemia with more than 90% blast being seen. And at that time, her white cell count had increased to about 127.7. Next slide, please. So with her treatment plan, she was on supportive treatment from 2011, with an EPO, and she was also put on danazol for a low platelet count, which was stopped in 2017 when she started having loss. The patient was waiting also blood and transfusions, also
Sorry, Gugu, I'm not sure if it's me or you, but I can't hear you. Can you hear me?
I've also lost audio.
I don't see her. I wonder if she's muted.
hi.
Gugu, can you?
I think,
Yeah, she's unmuted
Hello.
now. Go ahead.
I don't
okay.
know. I don't know. I couldn't hear you. So I don't know if you quickly finish out this case and then we go on to the last case.
Okay, so in 2017, then she had transformed to acute myeloid leukemia at the age of 55. And the plan was for her to have palliative care due to a poor performance state. She was then on hydroxyurea 1 gram daily, allopurinol and fluids, and also supportive management in the form of blood and platelet transfusions. She was also on analgesia with paracetamol and codeine. And in November, she was given cytarabine 100 milligrams IVI stat. However, the patient was last seen in our clinic in December 2017. The last patient is Mr. DC, who was a 66-year-old male who was referred in 2011 from Potchefstroom, who was married with 3 children, background of newly diagnosed diabetes, and was RVD negative. So he had presented with a persistent gum bleeding, and he's also developed large bruises and swelling, which were on the right arm. And he said he developed this after bumping his hand against a table, and also his left inguinal area. And he said he noticed this after going fishing, where the fishing rod may have rubbed against him. He then sought help with his general practitioner when a full blood count was done, and it showed a thrombocytopenia, blast, and macrocytes. However, this was not sent to us to see what percentage of blast that was. Of note, he had previously had surgery, a vasectomy 28 years ago, was uneventful, and was currently on metformin. He had moved to South Africa from England. However, he did have a very strong alcohol history where he drank alcohol daily, about six-pack beers and 1 to 2 tots of spirits daily, and said smoked about 4 cigarettes per day since he was a teenager, however, stopped 10 years ago and restarted. He had family, had siblings, 3 siblings who are all well, and no history of blood cancers or any blood disorders. He was a fairly stable patient, no signs of bleeding or bruising. However, he did have a high BMI, and clinically on examination, there was nothing really to note, but however, it was difficult to assess for organomegaly. So he was assessed as a refractory cytopenia with unilineage dysplasia, and it was not transfusion requiring at that time. So unfortunately, the blood sent in 2010, they only had an HB white cell count and platelets, so we weren't able to evaluate the blast percentage on it when he was diagnosed and referred. However, he had a low folate of 5 and was started on folate supplements, and his platelets were low at 11, and HB was at 11.4. He was then monitored, and in 2011, his HB was 10.8. He had a macrocytosis, Platelet count was still 13. Next slide, please. So the bone marrow done in 2011, the findings were those suggestive of a myelodysplastic syndrome, refractory cytopenias with unilineage dysplasia. However, cytogenetics were also unsuccessful. So with the information we had, his IPSSR score was that of 3, would put him at low risk, with a median survival of 5.3 years and a median time to 25% AML evolution at 10.8 years. So in 2012, he was then seen at the clinic and he had an increase in his white cell count to 61. His platelets had dropped to 7 and his HB was 10.9, and he had had 11% blasts on peripheral blood. And then a bone marrow aspirant biopsy was done for him. Next slide, please. So with his bone marrow aspirant TREF find, the final comment showed that the findings were best fitting a myelodysplastic syndrome, refractory anemia with excess blast 2. Next slide, please. So with his treatment plan, he was seen in 2011 where he was on folate supplements and supportive management. And in 2012, then he started having an increase in platelet requirements and was on supportive management. And the plan for him was to put him on the Vidaza trial. However, the patient was lost to follow up at that point. So those are the 3 patients. I don't think we've got time to continue, or should I?
It's fine, Gugu. I think understood. Is there anything that he didn't cover that you want to say in a few minutes, or?
No, I think he covered most of it. Yeah.
Okay. All right, so we will stop there. There were a few questions here. I think Moses mentioned something about the hour rods, and there's a question, any idea why the presence of hour rods would make myeloblasts so virulent? And even if the myeloblasts are less than 10%, one would have to classify the MDS as MDSE with excess blast 2. Does that confer poorer prognosis? If so, why not including more? So, gosh, Rita replied here. She says that the hour rod query seems to be based on retrospective studies. I don't know if Van's still on the call, yes, and if he has anything. I'm not certain the significance of the hour rods.
Yeah, thank you, Charlene and Moses, for that question. So way back, long ago, in a land far from here, somebody described hour rods as being a poor prognostic factor in MDS, and that entered the FAB classification. So it's an historical thing. Subsequently, there's been a couple of studies trying to link hour rods with prognosis, with response to chemotherapy, and with risk of transformation to acute leukemia. Now, interestingly enough, almost all the studies since have shown either a favorable association for hour rods in terms of response to chemo, and most of these studies were done in patients with the old term refractory anemia with excess blast in transformation, so the old RAEB2, RAEBT patients. And I think there was one bigger study that showed no effect whatsoever. And then in most of those studies, it was found to be a predictor on univariate analysis. And often when you took into account blast count or cytogenetics, it lost its prognostic significance. So the FAB, it was one of the things in the FAB that was challenged, and why people wanted the FAB to be upgraded to something new. And since then, we've obviously got a couple of new things. But a nice quote from a historical point of view, or maybe 2 interesting things. The first is that hour rods were actually not first described by John Auer. They were first described by Thomas McRae. John Auer only described it about a year after him. and but our somehow got his name attached to it. But an interesting quote from Maurice Richter that you know for other reasons, he said that our rods occur in only one type of cell, myeloblasts, in only one part of the cell, cytoplasm, and possibly in only one disease, acute leukemia, which has obviously since been proven wrong because we now know that it can occur in myelodysplastic syndromes. But if you go way, way, way back to the first descriptions of our rods, they actually thought that Thomas McRae thought that the patient had acute lymphoblastic leukemia. And it became quite a thing that our rods were seen in lymphoblastic leukemia. And then at some stage, that whole concept was proven wrong more than 100 years ago. And people started moving towards or realized that it's actually in myeloblasts. So that's my brief answer.
Okay, that's very interesting. You always have all these interesting old stories, Vernon. They're very interesting. And
History
so
is
Jacques,
our foundation.
so Jacques says, I want to make a comment regarding MDS with 5q minus. I'm currently treating one. The only one I've ever treated, was treated only with transfusions for 5 years with misdiagnosis. When referred to me, I started lenalidomide at 10 milligrams daily, developed severe prolonged cytopenias. I got some advice from some colleagues, and apparently this is a good sign for eventual response. Had to wait about 2 months for cytopenias to resolve and restarted a lower dose. Now has a normal FBC on lenalidomide, 5 milligrams 3 times a week. Thanks, Jacques, for that useful, very useful information. And then Vernon said, you're strangely how low MCV if iron was normal. Where the HPH containing red cells, should also think of sideroblastic anemia, copper deficiency, perhaps. Okay, we should.
I was just referring to the one case where the MCV was for a long time between 68 and 71, which is very.
Our first case?
I think it was your second case, or it could have been the first case. I'm not sure now. But just to remember that a low MCV is not the typical thing we expect. And when you see it, one should think of other things. If there's no concurrent iron deficiency, and even in patients with iron deficiency, you often still find that the MCV is normal. So just remember, you get this acquired mutation in ATRX, which can lead to an acquired thalassemia with HPH present. I think Jacques also made a nice comment about it, about the alpha chain gene expression that is downregulated. And then there was also, just to conclude on the sideroblastic anemia thing, remember copper deficiency, especially in patients who've been in hospital for a long time, especially on parenteral nutrition, things like that. They can develop copper deficiency, often neurological features. And don't forget our TB patients on iron H, patients on linezolid, chloramphenicol, not used that much anymore. And in particular, alcohol. And many of these patients can be helped with vitamin B6.
Okay, thank you for that one. There was a case in blood, if I remember. Okay, Jacques says there was an image case in blood, if I can remember correctly, of our rods seen in mature neutrophils. I think a case of APL. Yeah, then Rita says abnormal promyelocytes that have matured under the effect of differentiation therapy. So those are all the comments. I don't know if there's anyone else that has questions.
While people think, I just need to say thank you so much for such a well-prepared session and excellent talk. Really enjoyed it. And I think it's a difficult topic, to present in an hour or an hour and a half, and very well done. Really enjoyed it. Thank you very much, KZN team. You flew the flag high and you put pressure on all the rest of us.
Thank you so much. Just a pity, these cases were from way back, and it's unfortunate that we could not get the actual slides to show the morphology and, get better information. But it's just to say that we are not seeing that many cases, and perhaps everyone needs to be looking for MDS in the lab. You know, I think we are not getting referrals in the last few years. We haven't had any. So perhaps for the registrars in the lab, please keep a lookout for these patients because we are not getting any. But with that, I'd like to say thank you so much for the opportunity, and hope everybody learned. I mean, I certainly learned a lot. And everyone have a good holiday next week. And I'll hand over to Vernon to say goodbye to everyone. Thank you so much.
Thank you, Charlene. Don't forget to register your attendance. Also, just to note that the sessions are recorded and we loaded onto a Vula site at UCT, which anybody can then look at afterwards. So for those of you who maybe was a bit late, please email Melanie Davids. I've put the email address in the chat box. You can just ask her for the link. If any of you came here on invitation of someone else and you're not on our mailing list, again, please email Melanie, and she will put you on the mailing list so that you can get the invites for these sessions. Then just a little advertisement for next week. So next week, Monday is a public holiday, the 2nd of May, so we will not have a deep dive. And then the week after, we have an international guest speaker, Professor Keita from Amsterdam, who will speak to us on chronic lymphocytic leukemia. And he is brought to us thanks to the kind sponsorship by Janssen Pharmaceutical. So I think it's going to be a great session in 2 weeks, and you will be well rested for that hour and a half. So we hope to see all of you there. With that, a lovely evening to all of you. And thanks for being so actively involved. Bye-bye.
Thank you. Bye.